Good evening, everyone. Myself, Dr. Mehul Thakkar, uh, welcoming you for the CCI webinar in the COPD series. But before I begin, let me pay my condolences and respects to the people who have passed away this week. This week has been pretty heavy, and we have lost a lot of stars from our galaxy. So, first is Dr. K.C. Raju Reddy. I hope you can see the screen. Yeah. Yeah. Please show the next slide, please. Dr. Rajesh Hari Prasad Toshniwal. He was a chest physician from Nanded. Please go to the next slide. And Mrs. Varalakshmi Nagoti. She was mother of Dr. Sharada Nagoti. I can understand it's a difficult time for her, and I'm very happy that she's been able to join in spite of these. With that said, CCI and myself, Dr. Mehul Thakkar, pay our respects to the ones who have passed away. So let's start with the webinar. This is the first webinar in the series of COPD. Our topic today will be based on the basics of COPD, and I have got an excellent panel and speaker set with me to help me out. So I would like to introduce each one of them. My first panelist is Dr. Sharda Nagoti. Welcome, ma'am. Dr. Sharda Nagoti is a pulmonary pathologist specializing in thoracic and lung transplant, and she is attached she is a lab director at Medicover Hospital currently in Mumbai. Welcome, ma'am. I'm sure this is a difficult time for you, but I'm grateful that you were able to join us today. My second panelist is Dr. Deepthi Krishnan. Dr. Deepthi Krishnan is an assistant professor in Hassan Institute of Medical Sciences, Hassan, and she's serving as an NTEP nodal officer from 2017 till date. She has an illustrious CV with multiple prizes won and multiple presentations and publications. Welcome, ma'am. I would also like to welcome Dr. Varuna Jethani. Dr. Varuna Jethani is an MD pulmonary medicine, and she is a nodal officer for TB HIMS since past 4 years. She has more than 35 publications and is member of many national and international societies. Welcome, Dr. Varuna. And last but not the least, Dr. Anirudh Saini. He's a senior consultant pulmonologist from Jaipur. So I would like to invite Dr. Anirudh to give his first talk.
Good evening, everyone. Myself, Dr. Anirudh Saini from Metromas Hospital, Jaipur. I am a consultant pulmonologist. So today I am going to talk briefly about the epidemiology and pathophysiology of COPD. So about the definition. Chronic obstructive pulmonary disease is a general name for the chronic airflow obstruction that develops most often as a result of chronic tobacco smoking but also after exposure to biomass fuels. And about the gold definition, chronic obstructive pulmonary disease (COPD) is a heterogeneous lung condition characterized by chronic respiratory symptoms, dyspnea, cough, sputum production, and/or exacerbations due to abnormalities of the airway, bronchitis and bronchiolitis, and/or alveoli emphysema that cause persistent, often progressive airflow obstruction. Now about the diagnostic criteria. So simply saying post bronchodilator FE1 by FEC less than zero point 0.7 as measured by the spirometry is the criteria of COPD. Some individuals can have respiratory symptoms and or structural lung lesions or physiological abnormalities like low FE1, gas trapping, hyperinflation, reduced lung diffusion capacity, rapid FE1 decline with FE1 by FVC ratio equal or greater than 0.7. That is preserved FE1 by FVC ratio. These subjects are called PCOPD. Now the term PRISM, PRI as a prism, preserved ratio impaired spirometry has been proposed for those with normal ratio but abnormal spirometry. Pre-COPD and PRISM are at risk of developing airflow obstruction over time, but not all of them do. Now about the clinical presentation. How may the COPD patient present at our clinic or OPD, or how may we suspect that a patient may be having COPD? So patients of COPD complain of dyspnea, activity limitation, and or cough with or without sputum production and may experience acute respiratory events also of increased respiratory symptoms, which are called exacerbations. Now we'll talk about the burden of COPD in our Indian setting as well as the worldwide. So it has been estimated that global prevalence of COPD is 10.3%, and it is estimated that number of COPD cases among those people who are equal or greater than 25 years of age will increase by 23% from 2020 to 2050. That is about 600 million COPD patients by 2050. COPD is the second most common cause of emergency admissions in some countries, as some studies have pointed out. And worldwide, COPD is the third leading cause of death, accounting for about 3 million deaths annually. So it is a huge number. And talking about COPD in Indian scenario, we see that COPD is the leading cause of death in India. So it is very important. Second leading cause of death in India. One third of deaths due to COPD are from India. And out of more than 500 million COPD patients in all over the world, about 90 million patients are in India itself. That is about 16% of the total global burden. And annually, out of about 3 million deaths worldwide due to COPD, about 30% of deaths due to COPD occur in India itself. So we can see here 30% of deaths due to COPD all over the world are occurring in India itself. So it means that whatever system we are following or whatever facilities we are having, we are still not able to treat or control COPD properly all over our country. So all of these factors result in a significant financial burden as well in all the countries. Now about the risk factors. So COPD results from gene, that is G, and environment E interactions occurring over the lifetime T. So together we get the getomics, Getomics, that can damage the lung and or alter their normal development or aging process. Now, as we all know, tobacco smoking and inhalation of toxic particles and gases from household and outdoor air pollution are the main environmental risk factors. There are also other environmental factors and host factors like abnormal lung development and accelerated lung aging. They also contribute. As genetics is concerned, the most relevant genetic risk factor identified is the mutation of SERPINA1 gene, which leads to alpha 1 antitrypsin deficiency. Now, about 95% cases are smoking related, typically greater than 20 pack years of smoking history. But still, COPD occurs in only 20% of the smokers, indicating that there is a probable genetic susceptibility. So passive exposure to cigarette smoke called ETS, environmental tobacco smoke, and second-hand smoking are also risk factors. It is estimated that in some places with high levels of air pollution, like Delhi NCR, an average person daily inhales smoke equal to about 13 cigarettes per day. So pollution is also an important risk factor, especially in those places with high pollution levels. In Indian setting, biomass fuel exposure, like chula smoke exposure, is also an important cause of COPD. So wood, animal dung, crop residues, and coal, which are typically burned in open fires or poorly functioning stores, may lead to very high level of household air pollution, especially important risk factor in low and middle income countries called LMIC, just like our country, India. And tobacco smoking is the leading risk factor for COPD in high income countries still, which accounts for about 70% of the cases. But in LMIC, tobacco smoking contributes around 30 to 40% cases only, whereas other factors become more important in LMIC countries like our country, India. And non-smoking risk factors now contribute about 50% of the global burden. So as we can see, the non-smoking air pollutants and other factors, they are not only important in India itself, but also globally, they are also very important. Now, occupational exposures like organic and inorganic dust, these are also risk factors. Chemical agents and fumes, pesticides which are used, they are also risk factors. Air pollution consists of particulate matter, ozone, oxides of nitrogen or sulfur, heavy metals also, some greenhouse gases also. These are also important risk factors for COPD. Now, genetic factors, as we have discussed, the alpha 1 antitrypsin deficiency is an important risk factor for the development of COPD. But now also numerous genetic variants associated with reduced lung function and risk factors of COPD have been identified. Asthma and airway hyperreactivity. So important risk factor for COPD, especially if it is poorly controlled. If patient is having asthma and over the long period of time he or she does not control it properly with proper medications and regular visits, then also it can lead to COPD. Chronic bronchitis is also an important risk factor of cause of COPD. And infections, history of severe childhood respiratory infections, they can also lead to COPD. Chronic bronchial infection, especially with Pseudomonas aeruginosa, is also important cause. And tuberculosis. If we consider our Indian setting, Indian scenario, then tuberculosis is a very important cause, very relevant in Indian scenario. HIV patients are also at increased risk of developing COPD. Now, about gender, generally male are thought to be more susceptible for development of COPD as compared to females, but later on some data show that there is equal prevalence. But poor socioeconomic status is associated with increased risk of COPD. That is definitely proven. Now about the pathophysiology. So what happens in COPD? Pathological changes can be found in the airways, lung parenchyma, and pulmonary vasculature. These include inflammatory and structural changes which increase with the severity of airflow obstruction and can persist on smoking cessation also. So some of these changes they are not going to go away after smoking cessation. They can persist. And inflammatory changes, increased number of macrophages in peripheral airway, lung parenchyma, and pulmonary vessels, together with increased activated neutrophils and increased lymphocytes. These inflammatory cells, epithelial cells, and other structural cells release multiple inflammatory mediators which attract inflammatory cells from circulation, amplifying the inflammatory process and induce structural changes. Asthma and COPD are associated with chronic inflammation of respiratory tract, but there are differences in the inflammatory cells and mediators involved in the two diseases. Albeit, some patients with COPD have inflammatory pattern with increased eosinophils and ILC2 cells similar to asthma. Now the structural changes, there is imbalance in lungs of COPD patients between proteases derived from the inflammatory and epithelial cells that break down the connective tissue components and antiproteases that counterbalance dissection. So protease mediated destruction of the elastin is an important feature of emphysema. Also peribronchial fibrosis and interstitial obesities have also been reported in COPD patients. Excessive production of muscle and fibrous tissue can also be there. Even lung vasculature can also be altered. Airflow obstruction and gas trapping is there. Hyperinflation can be there. Pulmonary gas exchange abnormalities. Alteration of ventilation perfusion distribution that is also found in COPD. And also, as we all know, pulmonary hypertension, long-term effects of COPD, long-term complication of COPD, pulmonary artery hypertension can be there. And as it has been observed, there are multimorbidities like skeletal muscle wasting, cachexia, ischemic heart disease, heart failure, osteoporosis, normocytic anemia, diabetes, and metabolic syndrome. These all kind of comorbidities are found in patients of COPD.
A very good evening to all of you and welcome to CCI COPD webinar series part 1. At the outset, I would like to thank CCI for giving me this wonderful opportunity and also Dr. Mehul for his kind introduction. So I'm going to talk about histopathology findings in COPD. So COPD results in pathologic changes throughout the airways and also the lung parenchyma, and these can be broadly divided into 3 categories. The first one is the chronic bronchitis, the second is the chronic obstructive bronchiolitis, and the third is the central lobular emphysematous destruction. So coming to the first, that is the chronic bronchitis. This is associated with failure of mucociliary system. There is enlargement and inflammation of submucosal glands, which are present in the large airways with hyperproduction and secretion of mucus, which is expectorated as sputum. So this is the picture showing this large airway. This is the respiratory epithelium. This is the cartilage, and here we can see these submucosal glands. And as we can see in this picture, there is hyperplasia, there is enlargement of these submucosal glands. So coming to the next, that is the chronic obstructive bronchiolitis. This is synonymous with small airway disease. There is alteration in small airways, that is the airways of about 2 millimeter in diameter without supportive cartilage. This is the major anatomic site responsible for airflow obstruction of COPD patients, and the obstruction is the result of inflammation and structural changes, which is also called as remodeling of the small airways, and these include mucous metaplasia, thickening of the airway walls due to fibrosis. There is increase in smooth muscle mass, resulting in narrowing of the lumens. So this is a picture of the small airway, and this is the surrounding normal alveolated lung parenchyma. And as we can see in this picture, there is fibrosis which is surrounding this the lumen of the small airway, and this fibrosis has resulted in stenosis of this small airway. The third is an increase in air spaces beyond the terminal bronchioli, which is the result of central lobular, also called as bronchocentric emphysematous destruction. And these changes are especially obvious in the upper aspects of the lung lobes. So this is the picture of the emphysematous changes, and this is a central lobular emphysema because these emphysematous changes are present nearer to the bronchovascular bundle. So here there is enlargement of the air spaces and also destruction of these air spaces. So now I'm going to show you some biopsy cases of COPD patients. This is the endobronchial biopsy of a bronchial asthma patient. So here there is the lining respiratory epithelium. below which is the basement membrane. And as we can see in this picture, there is thickening of this basement membrane. Below this is the subepithelium, and hyper view of this subepithelium shows a lot of scattered eosinophils. Below this is the smooth muscle, and here there is the smooth muscle hyperplasia. These are the bundles of smooth muscle, and there is hyperplasia of the smooth muscle bundles. So these are the histological features seen in the endobronchial biopsy of a bronchial asthma patient. And then we have severe emphysema from a patient who had undergone transplant, a COPD patient who had undergone transplant. This is the biopsy picture of the explanted lungs. And here we can see there is huge enlargement of these air spaces and also destruction of these air spaces. And then we have this entity which is called as smoking-related interstitial fibrosis. This is a distinctive pattern of interstitial fibrosis which is exclusively found in smokers. And these changes, this smoking-related interstitial fibrosis, which is also called as SRI, is encountered in lobectomy specimens of lung cancer patients in smokers and also in the explanted lungs of COPD patients. So the distinctive feature of this SRIF, of this interstitial fibrosis, is the presence of this highly lysed ropey eosinophilic collagen. And along with this, there are other features of smoking-related interstitial lung diseases like presence of this emphysema and also respiratory bronchiolitis. Respiratory bronchiolitis is nothing but accumulation of these smokers' macrophages in the respiratory bronchioles. So this entity is called as smoking-related interstitial fibrosis. And then we have the combined pulmonary fibrosis and emphysema, also called as CPFE, where there are changes of pulmonary fibrosis, that is usual interstitial pneumonia pattern, UIT pattern of fibrosis, and also emphysema, emphysematous changes in the same lung. So as we can see in this picture, the right side is showing this emphysematous changes with the enlargement of the air spaces, and the left side is showing this dense interstitial fibrosis. So this entity causes quite a lot of challenges, both clinically as well as pathologically, because presence of emphysema modifies the clinical and pathological picture. So this is the YouTube video of Fresh Air series episode, which I have done on smoking-related interstitial fibrosis with Dr. Matt from Western University, Ontario, Dr. Irini from Spain, Dr. Raghavendra from Virginia, and Dr. Sanjay from Cleveland Clinics. This is available in the YouTube. And this is the paper on smoking-related interstitial fibrosis about which we discussed in this video. And this paper is also available in the internet. You can download it for further reference. So thank you very much.
Okay. Thank you, Dr. Anirudh, Dr. Sharada, for an excellent talk. And I believe you have set the ball rolling. I must say this webinar, we are going to focus mainly on the basics of COPD here, the pathophysiology and the diagnostics. We'll not be venturing into other areas. This is a multi-part series. This is a brainchild of our chairman trustees, Krishna sir and Dr. Narayan Pradeep, under Dr. Ashish Dubey and Dr. Anil Maske, and our very own Dr. Vijay Kumar, who guided us for this webinar. And let's start with the panel discussion. As I said, we'll be focusing mainly on pathophysiology and diagnostics, and we'll take the questions as they come along in the chat box also. Okay, so first question, I hope I'm audible, is to Dr. Deepthi. We've all discussed something about COPD. We all know what is COPD, but again, since this is the basics of COPD, I'll start with the first basic questions. What are the common risk factors for development of COPD?
Thank you for the question, sir, and thank you for CCI, Dr. Krishna sir, Dr. Pradeep sir, Dr. Vijay sir, Ashish sir, Anil sir for this opportunity. I think Dr. Anirudh's talk has pretty much covered the risk factors very well, and GOLD as such has condensed this concept into gene and environment interaction. So even the thought that a simple fetus in the uterus, if exposed to smoke during pregnancy, and in later life, if there is any second hit by another smoke exposure, that itself is a risk factor for future COPD. Such a thought process itself is sufficient to highlight the fact that smoking can be a risk factor in utero and outside the uterus as well. So when we are speaking about smoking, not just during pregnancy or later in life, even a person who is exposed as a second-hand smoker is equally chanced for this COPD to happen to them. And the other factor are the common outdoor and indoor air pollutions that can happen. So we are now more aware that when we are conducting studies of COPD in India, actually 50% of the cases are due to non-smoking causes, that is biomass fuel and indoor house pollutants. So I think majority of the low income countries will have non-smoking causes to be more obvious than smoking. And so non-smoking COPD has become the highlight for gold this year. And I think we'll be having a lot of discussion about that in this talk today. And I think apart from that, occupational exposures, maybe another 10-20% of causes is occupational causes. And the focus also falls on the genetic components. So as Anirudh sir has already mentioned, there is the SERPINA gene, but apart from that, there are other genes like MMP1, and there is the HHIP. So all these genetic factors are also being studied and coming into focus as part of research, so that somewhere down the lane we can target these genetic factors. Particularly now there was a study that came out, I think somewhere in during this year 2025, from a Canadian guidelines, the society, where alpha-1 antitrypsin augmentation therapy was being discussed. So I think the genetic component is also equally important, and the focus should not be only on smoking when it comes to COPD.
Thank you. Thank you, Dr. Deepthi. In fact, I think in one of the webinars I had heard, the non-smoking COPD component probably is more in India. The kind of pollution that we are exposed to, probably all of us, even non-smokers, are exposed to that. So coming to the genetic factors that you said, Dr. Varuna, can you just elaborate what role does genetics play in the development of COPD?
Yes, sir. Good evening, everyone, and thank you, CCI, for the opportunity. Talking about the genetic factor, like COPD development is not just limited to smoking or an environment disease. Individuals have the varying genetic susceptibility that influence their risk. First, talking about the most important, as we always know, is the SERPINA deficiency and the gene mutation, which is leading to alpha-1 antitrypsin deficiency, and then the lack of protection, and there is a lung damage and the emphysema in the early phase of life. There has also been studies like genome-wide association studies that have identified many genome for these diseases, like we have FAM13A that induces the reactive oxygen species, and HIP, which increases the inflammation, TERT, that are telomere pathway mutation, all leading to COPD, fibrosis. Other various genes have been like CHRNA3, CYP286. So these all gene mutation leads to the release of the reactive oxygen species and the increase in the inflammation, and further leading to the COPD.
Okay, thank you, ma'am. So as we all know that every disease probably has some genetic basis. So I think it is truly exciting time in COPD, probably where the more we study genetics, maybe the therapeutics can be targeted towards specific risk factors. Coming to the next question, Dr. Anirudh, are there any prenatal risk factors, which lead to development of COPD?
Well, some of it, Deepthi madam has already discussed that about the smoking exposure during pregnancy. And so, first of all, I would say that about the, as already discussed in the gold guidelines, the socio-economic status of the parents, it affects the birth weight of the child. And birth weight of the child is linked to low birth weight of the child is linked to the abnormal lung growth and development. So it makes if the child is of low birth weight, then it makes it more susceptible to develop COPD later in life. So in that case, in that way, the socio-economic status of the parents, a prenatal factor, it impacts the risk for COPD. And as Deepthi madam has already told, if mother is smoking during the pregnancy, then the fetus is it has got it affects the fetus. Uh, it has got detrimental effect on the fetus, and it also leads to abnormal lung growth and development. And here, as the gene and the environment hit the child has already taken during the prenatal life itself. So in the later in the life, how if the second hit is there by the environment, how that child, that patient is going to respond to it. That it is definitely gets affected. So it is also a risk factor for prenatal risk factor for development of COPD.
Thank you. Thank you. So as we can see, our risk factors start not only when you start inhaling or even before you start inhaling, the COPD risk factors can come from your mother also. Coming to the next question, Dr. Deepthi, there are a lot of terms which are floated now. We see a lot of gold guidelines also coming up with few terms: pre-COPD, young COPD, early COPD. Is there a difference in these terms? Why do we label them separately?
Mehul sir, thank you for the question. Though there are a lot of terms, but I think as such, when we are applying it clinically, only two terms are important, that is young COPD and pre-COPD. Early COPD has not been clearly defined by GOLD as such. Even they are trying to focus more on young COPD and pre-COPD. But basically, early COPD, what they want to say is let the term be used more during research settings and experimental settings where we are trying to focus on how the disease is behaving in its early stages. So when there is a research happening in early COPD conditions, how the pathology is, how the blood circulatory markers are. So I think that those kind of clinical setting, experimental setting, we can use the term early COPD. Whereas young COPD is where the actual, what we are thinking in terms of young, that is where the actual chronological age matters. So the moment we think of COPD, we have learned from undergraduate and postgraduate level that it is, you think of COPD above the age of 60. So this concept has changed in the recent years because of all this non-smoking factors, genetic factors, and we are seeing more number of cases in the younger age group. So from 20 to 50 age group, we are coming across cases rising, particularly in females. And this young COPD is basically the term used for COPD in 20 to 50 age. Whereas pre-COPD is a more definite clinical application of the term where we are finding patients who are having symptoms or even some anatomical structural abnormalities, but their spirometry is turning out to be normal. So we are not able to put them into the bucket or the basket of COPD, but at the same time, the presentation is there. We are aware that any moment these patients are going to end up in our OPDs with a proper COPD spirometric report. So the awareness that there is a subgroup of people who are symptomatically present as COPD. Structurally, there is evidence, but spirometrically they are performing well. So we should be only aware that keep them in your follow-up and get a regular spirometry done, because you never know when these people are going to turn up with a proper obstruction on their reports.
So it's very easy to get confused with the term, but you made it pretty simple. So the terms pre, young, and early COPD, I think when we see a patient, it doesn't matter to the patient what we label them, but you should, as pulmonologists, be aware of all the terms that are used. Coming to the next question, Dr. Sharada, I would like to ask you, can you enlist some major pathological changes that you see in COPD patients? You've already described it in your slides, but can you just enlist them here for the viewers' sake?
So the pathological changes in COPD patients are seen in the mainly in the small airways and also in the lung parenchyma and also in the vasculature. So these can be broadly categorized into chronic bronchitis, chronic obstructive bronchiolitis, and emphysematous destruction. And in the chronic bronchitis, as I've shown in the picture, there is hyperplasia of the submucosal glands, and this causes hypersecretion of mucus, and this leads to the expectoration of sputum. And in the chronic obstructive bronchiolitis, the main pathology is in the small airways. This is also called as small airway remodeling, which is seen in the form of mucous metaplasia, and there is mucostasis in the small airways, and there is inflammation and fibrosis of these small airways, and this leads to stenosis of the airway lumens. And then we have the emphysematous destruction, where there is destruction of the alveolar septal walls, and there is enlargement of the air spaces. And these emphysema is mainly the centrilobular emphysema, that is, the emphysematous changes are seen around the bronchovascular bundles. So apart from these, in severe cases of COPD, we find even changes in the pulmonary vasculature in the form of pulmonary hypertension, medial hypertrophy, and intimal hyperplasia of the arteries, and arterialization of the muscularization of the arterioles. So these are all the changes that we see in the biopsy of COPD patients.
Yeah, thank you, ma'am. Thank you for enlisting. In fact, I think Sadhvi sir had said in one of the webinars that small airway disease sometimes can be a predominant disease, and we might miss it if we don't look for it. So-called early or mild COPD cases in such case. But also the same next question is to you only, Dr. Sharada. Is there a difference in the pathophysiology in a non-smoker COPD cases versus like a smoker COPD?
Yeah. So basically, the pathophysiology is the same in smokers and non-smokers. That is airway, airflow limitation, and airway inflammation. But the pathogenesis is different in the sense that some studies like the Major et al. Study showed that neutrophils are the main inflammatory cells in case of non-smokers and smokers without emphysema, while in smokers with emphysema, the major inflammatory cells are the T lymphocytes, especially the CD3 and the CD8 cytolytic T cells. So the pathways are different. And another thing is apoptosis is the main mechanism of lung parenchymal destruction in case of smokers with emphysema. So the pathways are different in smokers. The main pathway is a T lymphocyte mediated pathway, especially the CD8 T lymphocytes play a major part, and apoptosis is the main mechanism of destruction. And apart from this, in the exhale breath condensates, it is found that interleukin-6 and leukotriene-4, these are more in case in the alveolar lung parenchyma of smokers with emphysema when compared to the non-smokers. So in this way, the pathogenesis is different, though the pathophysiology is the same.
Thank you, ma'am. In fact, clinically, I would say when it was my thesis comparing males and females of COPD, I did my PG from Jaipur only. So there we did see a lot of small airway in non-smoker COPD. So maybe what you said made sense. You can sometimes, if your PFT is missing out on your normal large airways look normal, maybe look at the small airway disease. And if you do a biopsy, you might see the pathological changes as Dr. Sharada has mentioned. Moving on, the next question to Dr. Varuna.
Yes.
When we say COPD now, we are speaking about genetic factors, we are speaking about smokers, non-smokers COPD. So there are some proposed etiotypes in the GOLD guidelines for COPD. Can you describe them or can you name them?
Yes. As sir, you said there are genetic factors, smoking. These are all included in the etiotypes as per the GOLD, starting with the genetically determined, that is COPD-G, which is classified as the alpha-1 antitrypsin 1. Then due to abnormal lung development, which is like premature birth is there, that is called as COPD-D due to development is that. Third, talking and most common, the environment, smoke, the cigarette smoking, the passive smoking, and the vape, the cannabis used, and even the pollution that is causing it. So it's a COPD-C due to cigarette smoking or COPD-P. The next is due to the infection, due to any infection like tuberculosis associated is most common development with the COPD. Childhood infection, if initially 2 years of the life the patient has more of infections, then later on phase they develop with the COPD. And the category last is COPD and asthma, and the COPD with like an unknown cause also is there. These are all classified in the etiotypes of the GOLD classification.
Thank you. So these etiotypes are going to have an clinical implication when you're treating the patient, or maybe when you're diagnosing a patient. You might have a patient who's a non-smoker, but might come with symptoms suggestive of COPD. So keeping that in mind, Dr. Anirudh, what are the clinical indicators when you're considering a diagnosis of a COPD patient? Now we know there are a lot of ETO types. So then what would you look for in a patient when diagnosing a COPD?
Well, COPD is a obstructive airway disease. So the patient, by the clinical indicators, we mean symptoms and signs. So the patient will come with the complaints of dyspnea. Dyspnea could be with exertion or could be even at rest, and chest tightness, wheezing. Patient may complain of fatigue or activity limitation. There could be cough also, complaint of cough also, which could be with or without expectoration. These could be the complaints the patient may come with, and on the signs that on examination, what we could see, there could be tachypnea or tachycardia, or the patient uh, could be having pursed lip breathing, could be having peripheral edema. It is advanced COPD with signs of core pulmonale, and on examination, if we measure the weight and height and calculate the BMI, maybe the BMI could be low, and muscle wasting and other features associated with the COPD or comorbidities we can see, and also the chest movements could have been decreased. Uh, the shape of the chest, we could find a barrel-shaped chest, and on the use of accessory muscles of respiration could be there, like sternocleidomastoid, and on percussion and auscultation also, we can have some findings like on percussion there could be hyperresonance, on tidal percussion the diaphragm could be found not moving properly, or in auscultation we could auscultate, we could hear wheeze or decreased breath sounds. So these are the clinical indicators that we should be looking for a patient suspected of COPD.
Thank you. Thank you, Dr. Anirudh. So patient can come with anything. Patient can come walking in a clinic with just a mild cough, which is not going, and you might diagnose him with COPD, or patient might come with an exacerbation, and you might diagnose a COPD. Then taking the full history and the clinical examination, as you said. Before moving on to the next question, I would like to announce that even for basics of COPD, there are more than 1,142 logins. So that's a good number for people who to know that COPD now no longer is just the same chronic bronchitis and emphysema, the blue bloaters and the pink puffers. There's not many nuances to the pathology and the diagnostic modalities. So this is an excellent number, and this is an excellent number for all our panelists here. Thank you. Moving on, going to the next question, Dr. Deepthi, we have got the clinical indicators, as Dr. Anirudh has said, but all might present some other diseases also. So what would be the differential diagnosis of COPD patients?
So it's a very basic question. I think most of us are aware of the common differential diagnosis like asthma or bronchiectasis. But a few more not so common DDs which I would like to include and which are coming into focus now is the TB associated obstructive lung disease. So TOPID is becoming talked about DD for COPD now, and more so because after the recent study by Dr. Salvi in India, where we got to know that majority of our COPDs had associated tuberculosis, and tuberculosis was in fact the cause for their obstructive airway. I think TB is a important DD for us in India, particularly. Apart from that, post-transplant obstructive obliterative bronchiolitis, or in non-smokers, we can consider the term diffuse bronchiolitis. So these are all mostly diagnosis of CT. So we are seeing a clinical picture of COPD, but ultimately the diagnosis should be from the bare minimum history from their examination and from their CT findings. Spirometry as such, I think in this case, as a differential diagnosis, may not be very helpful because we are seeing obstruction in asthma now. That is that asthma COPD overlap syndrome, and we are finding the post bronchodilator, reversal in a few cases of COPD. So not much help from there, but I think a basic workup should include Spiro because we need to know small airway involvement. We need to know about whether they will improve with ICS. So lot of importance for Spiro is there, but anyway, when we are considering the differential diagnosis, the focus should be based on basics like history and focusing more on how the pattern is, the seasonal variant, the exposures, the occupation, and of course the CT findings, as I told you. Like for example, in the obliterative bronchiolitis after a post-transplant, there is the findings of hypodense areas when the CT has been taken on expiration. So, or there are some centrilobular nodules in the pan-bronchiolitis picture. So all these findings from the CT is also equally important. I mean, how many of us really consider taking a CT in a case of COPD? So COPD is more of a downright, on the spotter for us in an OPD setting. But the workup is important. We may be missing these less common conditions when we are treating a COPD-like picture.
Yeah. So well said. So most of the chronic cough that goes in the community is treated by probably family practitioners and people from the medical side. And they might consider it to be just recurrent LRTIs and just give multiple antibiotics. When a patient walks in our clinic, our alarm bells go up. Probably this could be COPD. But as you said, we need to keep our eyes open for other differential diagnosis. So taking a proper history, 70% diagnosis should come from your history, background check of the patient, occupation, everything. Then coming to the spirometry, which should be available probably in your OPD, and then going to the radiology, and then you can have a diagnosis within a day. So that's a good way of diagnosing it. Coming to the next question, continuing this discussion further, Dr. Varuna, we discuss symptoms of COPD as breathlessness. Then, but how do we grade that breathlessness? What is the MMRC coding? What is the CAT assessment that you do in a COPD patient when the patient walks in your clinic?
These two scales are the most important. Whenever we start with a course, these are the basic things we must know. So starting with the first, the MMRC. The MMRC is the Modified Medical Research Council's grading. It's grade from 0 to 4. And 0 means there is a breathlessness on exertion. 1, while walking on upper hill. 2, when the walks slower than the people of the same age and has to stop for breath while walking on its own pace because of the breathlessness. 3 is while walking up to 100 meters and he has to stop for breath due to breathlessness. And 4th is while dressing, undressing, leaving the house. That's a MMRC grading. The CAT scoring has a more system of grading. It has a 8 points. We have to classify as well the 8 points according to the question asked, and the grading from 0 to 5. Like if the patient has never coughed, so it would be a 0. Depending upon the cough intensity, it has to be graded from 0 to 5. Depending on the mucus he produces, like no mucus, no phlegm, then it's 0. More of the mucus, then it's 5. If the patient feels chest tightness or not, so if there is no tightness, it's 0. And it increases on, then it would be graded as 5. Next, that's point that are covered as per the breathlessness on patient walking up a hill or towards the stepping in forward. And activities are asked whether it's limited or not limited. If it's again not limited, he is okay and comfortable, then it's 0. If the patient has limited activities at home also, it's at grade 5. The maximum is at the grade 5. And leaving the house and not, we ask about the sleep, whether he's able to sleep soundly, then it's 0. And if he's not able to sleep soundly, then it's 5. And last would be an energy, that is he has to take for a lot of energy to do each work or not. So these are basic 8 questions that are asked in the CAT score, and the patient is characterized from the 0 to 5.
Thank you. Thank you. This CAT scoring and MMRC grading are not useless. I would say practically, if you see an OPD prescription or an OPD letterhead of a good clinician, he would mention the history, he would mention the grading, and he would mention it at every follow-up. So you can come to know if the patient is getting better or no. And maybe unknowingly you do categorize the patient in MMRC grading, but mentioning it on your prescription makes sense. So coming to the next question, Dr. Anirudh. So if you have a clinically suspected patient of COPD, you have taken the history, you have taken the background check, family history, what tools would you use to diagnose a patient for COPD?
For diagnosis of COPD, as we all know, there are very basic tests. Most important is the spirometry, the post-bronchodilator response of the patient. So, post-bronchodilator FE1 by FEC ratio. If it is less than 0.7, then the patient can be diagnosed as having COPD. Also, if we do a PFT, we can see subjects who have the preserved ratio but impaired spirometry. That is, ratio is more than zero point 0.7 or about zero point 0.7, but the FE1 does not match up to the indicated age criteria, age and height and weight uh, recommended. So these such patients may not be diagnosed as COPD at that point of time, but we can counsel them that they are at increased risk of developing COPD later in life. So if they are having such a lifestyle as smoking and other things, so we can counsel them properly about that. And this is and also DLCU, the complete PFT, the DLCU, it decreases in COPD patients due to emphysema because a lot of the surface area is decreased for the gas exchange to take place. Uh, Also, we can go for basic radiological tests like chest X-ray, which can show us signs of COPD, COPD changes like hyperinflation and tubular heart, or maybe some abnormal finding we can see, or if the X-ray is not clear or doubtful, then we can go for HRCT chest. HRCT test as such is not needed for diagnosis of COPD, but if the X-ray is doubtful, then uh, I would rather go with HRCT test because once the all the detailed lung image is there with us, then it becomes easier for us to treat the patient and also to counsel the patient about following a healthy lifestyle and about taking the proper medicines if the patient is having any respiratory condition. And also ABG, the uh, as such, ABG also not required for diagnosis of COPD, but ABG is an important test because if the patient is having increased CO2, PCO2, then we can see that his or her condition is progressing. If the patient is having hypoxia, PO2, less PO2, so the patient is having PO2 less than 80, or the PCO2 is normal, it is 35 to 45 millimeter of mercury. If it is more than that, and the kidneys are compensating to keep the pH normal, so these all we can assess by the ABG. So,
Thank you. Thank you. So if you have a patient, let me sum it up. If you have a patient of COPD which you're suspecting based on history, clinical examination, has stable COPD, has walked in your clinic, probably the most important tool is going to be your history. Then probably something which is available at your bedside is your spirometry and maybe a blood gas or a radiology which is available with you just to rule out differential diagnosis which you have. So keeping that discussion in mind, Dr. Deepthi, what can you describe what is the role of spirometry in COPD?
The concept of COPD was itself based on spirometry. We knew that COPD is a spirometric diagnosis more than anything else. But that has changed, and after all this discussion today, I think we know that spirometry is one more additional supportive diagnosis for COPD rather than the gold standard. But the spirometry that we are presently conducting in our regular clinical setup, there are a few things I want to reinforce about the standards that are being followed. That though majority majority of us do conduct three good, forceful expirations and take the best out of the three. How many of us really look to see that the difference between the best sample and the other samples should not be more than 5% or 150 ml? These points. And then there is the fact that when we are doing a post bronchodilator values, if we are using a short acting beta agonist, we need to make sure that we are waiting for 15 minutes before the next sample is taken. And if we are using a short acting muscarinic agent, we need to wait for at least 30 minutes. So these simple points need to be reinforced in a clinical setting when a spirometry is being conducted. But that apart, coming back to the question about the role of spirometry, other than the diagnostic purpose, I think more importance should be paid for the prognostic purpose of this spirometer, where we are aware that a baseline FEV1 of the patient is so and so, and whether the patient is improving with our treatment or not, or whether there is a decline in his lung function. In fact, as Dr. Anirudh had already mentioned, the small group of patients with the preserved ratio and impaired spiro, the PRISM patients, these patients are our lookout patients. These are the patients that we need to, make sure that we are repeating the spirometry so that we catch them early. We are able to treat them early. So these prognostic importance of spirometry is the more important role for spirometry in COPD. Apart from that, of course, when we are trying to think of any interventional procedures in COPD patients, we need to have a basic spirometry, whether it is for lung reduction, lung volume reduction surgeries, or whether it is bronchoscopic, or whether it is pneumonectomy, whatever we are planning. We need to have a basic spirometry workup. So that again, the importance of spirometry comes there. I think, as I said, a follow-up purpose is there, a prognostic purpose is there. And once we are aware that a spirometry, if the patient is willing to get a spirometry done, then that is our basis for the follow-up. Otherwise, technically, we see improvement in the second visit itself. Once they have started with bronchodilators, once they have started with good inhaled steroids, we are seeing good improvement clinically. But what is the basis for us to step down the treatment or to step up the treatment? Again, for all these purposes, we need a spirometry.
Yeah, so I would just put it in this way. Spirometry is a tool which you can use for a quick diagnosis. If patient is in your OPD, you have a spirometry in your office, you can do it quick diagnosis. You have a history, you have a spirometry, you get a diagnosis. Also, as you said, for prognosis, has the patient improved? Sometimes the patients need an objective evidence of improvement. The relatives want spirometry would help there. And it's not just the pre-op fitness for the lung thing, but if a patient has to undergo, say, a CABG or maybe any other hernia surgery, a spirometry is a simple office procedure which you can do to judge fitness, also along with the history that you have. But it's not all a rosy picture. So then there are some limitations what a spirometry has. Dr. Varuna, can you tell us what are the limitations of the spirometry test in COPD patients?
Yeah, spirometry is important for the diagnosis, but for the treatment, we should not rely always on that values itself because of the certain limitation it has. Main is the effort dependency. It has to be like patient cooperative. Patient has to exhale with the maximum force expiration is required. That is sometimes challenging for the patient for the maximum expiration, and the reproducibility and variability, as ma'am covered, that is also affected by the patient effort, technique, even the equipment quality, that is also an issue. And the gold has fixed the ratio that of FE1 FVC is fixed, but it sometimes misinterpret and sometimes and underdiagnose the patient, because it sometimes which is the ratio will be more reduced in the old age person, and that would be an underestimation for a younger person. So we have to see for the symptoms also, and then see for the disease severity.
So, in short, spirometry is good. but know the limitation, how it has been performed, where it has been performed, what values have you taken to judge your patient's data as compared to the standard that you have used. So along with this spirometry, Dr. Anirudh, are there any other functional tests that can be done in a COPD patient?
So there are some basic functional tests like the bedside spirometry, bedside PFT of breath holding, breath holding test, the Snyder's match blowing test to assess the capacity of lungs of a patient, the forced expiratory time test that in the forced expiratory time test that if the patient is asked to inhale maximally and then try to exhale as rapidly as possible to complete the inhaled air completely out of the lungs and simultaneously the patient auscultates with the stethoscope watching the time taken on a stopwatch. So if the time taken by the patient is more than 6 seconds, then it's like it fits the criteria of obstructive airway disease. So these are the basic, some of the basic tests, and other important tests are which many of us do in our clinics. That it is a 6 minute walk test and shuttle walk test. So in 6 minute walk test, 2 points are marked 30 over 30 meters distance, and the patient is asked to walk between them to and fro and try and for 6 minutes, and the patient has to try to keep increasing his pace, the pace of walking. The final distance that the patient covers in those 6 minutes is the most important parameter measure, and also the saturation is measured. If there is drop of saturation, these all give us an idea of the capacity, the lung function of the patient. Shuttle walk is also a similar test, except that there is some automated audio that asks the patient to repeat, increase his or her pace while walking, and the distance between those 2 points is like 10 meters. And another important thing is CPET, cardiopulmonary exercise testing. So basically, it is also known as oxygen consumption test. So what it does is that what its target is to determine how well the body is able to take in oxygen and consume it. So how it is done is that the patient's blood pressure, heart rate, oxygen saturation, ECG, they are monitored, and the patient is asked to walk on a treadmill or run on a treadmill, and or either or also there is cycle ergometer on which the patient is a kind of bicycle on which the patient sits and the patient cycles. So these parameters of blood pressure, oxygen saturation, these are all measured, and it gives an idea of that how well the heart and lungs are able to tolerate the exercise, and it gives an important assessment of the severity of the heart failure and COPD. So this guides us for the treatment of the patient. So apart from this, some other functional tests have also I have read about, like one is body balancing test, because in COPD the patient may find it difficult to balance the body and get up and go test. And there are like many such basic tests, but the most important ones are still the 6 minute walk test, shuttle walk test, and the cardiopulmonary exercise test.
Yeah, so as you said, we can have these kind of tests if until and as and when probably we don't have availability of CT or the PFT showing some query picture. Coming
Yes, sir.
to similar lines, like if you have a PFT which is not very classical, so there is a term Dr. Deepthi mentioned. Dr. Deepthi, what is the term prism? You mentioned something about something called as prism. What is that?
The PRISM is a mnemonic that a PRISM. So in that PR is the preserved ratio. We are well aware of FEV1 FVC ratio of 0.7. So that ratio is what is basically guiding us in COPD. When the ratio falls, we are thinking of obstruction. But in these cases of PRISM patients, the ratio is preserved. There is no alteration. They have a good ratio, in fact. But it is the other spirometry that is impaired. That is the IS, where we are talking of FEV1, where if the ratio is good enough, we are expecting FEV1 also to be more than 80% of the predicted. But these patients are falling short and they are having a lesser FEV1. So there is a very small subgroup of hardly around 10% of your patients who may actually be having this picture. But what again, as I have already mentioned, the focus should be that these are the very people who are going to end up with COPD in the future. And though it may be around 20-30% who will ultimately end up in the obstructive basket, but we should be aware and we should be able to look out for these patients who are ultimately going to end up with a proper full-blown COPD picture. So a few predictors for this I would like to mention. It is the female gender, older age group, and then there are those who are current smokers and who are not going to show any sign of quitting. So those patients are the ones who are we need to look out for. We need to tell them that, see, you're already a PRISM patient, and another few years you're not going to stop smoking. You're going to end up as a full blown COPD. So not just a easy way for us to convince them to quit smoking, but for us, basically, for our own practice, we need to know that the earlier we are able to catch these PRISM patients, the lesser the chance that they are going to end up with a full-blown COPD. That is the importance of PRISM.
Yeah. So in such patients, as you said, if they're difficult to handle, if they're not able to quit smoking, maybe the other functional test, what Dr. Anirudh mentioned, it might light a bulb in their head that they are suffering probably from some lung disorder. So coming to the next question, we have decided the clinical scenario, we have decided the etiotypes, we have decided what test to do. Dr. Varuna, is there any role of some blood test in COPD? Would you do some blood work in your routine COPD stable patients?
Yes, sir. There is actually, I would characterize the blood test for the three categories. First, the blood test for the diagnosis purpose. We are talking about the genetics. So, if we are suspecting for that, then for the diagnosis purpose, we would require an alpha-1 antitrypsin deficiency to be ruled out. Second, if the patient is diagnosed with a COPD, now we have to see with the further complications also. So the blood test like arterial blood gas analysis for the PO2 and the PCO2 level. The hemoglobin we have to see for the polycythemia or the anemia, that is complications with that associated. And the third most important being the biomarkers that assess the disease severity, the progression, and the mortality risk also. Like we have CRP, LDH, even the basic neutrophil lymphocyte ratio, which we have also studied at our center also, is also a very important tool and the basic thing that assess for the COPD severity, other like eosinophils and all. So these are all blood tests that has to be done in some patients as per the requirement.
Yeah, so even the eosinophil count might be useful to decide on what kind of treatment you're offering to the patient, or is there an asthma COPD overlap? So getting the basic blood work done is sometimes helpful. Next favorite test that we do to diagnose any patient for a pulmonary disease is a CT scan. So it has already been spoken, but Dr. Anirudh, can you just explain in brief, is there any role of CT scan in COPD?
So CT scan, it gives us a detailed image of the lungs, and it helps us assess the emphysema, air trapping, and the airway disease. So in COPD patient, the COPD is just a spirometric diagnosis. But what is leading to those spirometric findings that we can better learn if we go in for radiology, if we go in for CT scan. So the CT scan is much needed for evaluation of patients. It is important in lung cancer screening also. In it it is useful in pre-operative evaluation also. If to see if the patient, if the patient is, there is a COPD patient about to undergo surgery, so whether it is a surgery for COPD like lung volume reduction surgery or transplantation, is it really going to benefit the patient? And as I just said that because the COPD is just a spirometric diagnosis, and what thing is causing those findings? So if we do a CT, then we can see whether why it is like that, whether it is due to post TB sequelae, whether it is due to bronchiectasis, or some other cause. And also we can see if there is air trapping, and if many of the COPD patients are having other comorbidities, and even ILD, they may be having ILD also. Along with COPD, they can be having ILD also, and for that, CT is a very important diagnostic tool. And and what the some of the CT features that we can see in COPD are like emphysema, which could be centriasinal emphysema, paraseptal emphysema, panasinal emphysema, or isolated due to some scar. And air trapping we can see. So air trapping can be visualized as the dark areas on the CT scan, which remain dark in inspiration as well as expiration. And we can also see mosaic pattern, which is the normal lung tissue interspersed with some air trapping areas. And we can see the flattening of the diaphragm, bronchial wall thickening can be seen. In this way, this HRCT test is in fact a very important test. Only the drawback is that it gives unwanted radiation dose to the patient. But if the age of the patient is somewhat high, say above 50 or above 60, I personally feel that at least one CT test of such COPD patient should be done. Or if the symptoms are severe, or if the patient is not responding to not responding adequately to the treatment of COPD, then definitely at least one HRCT test should be done.
Yeah, so as you rightly said, CT scan can be done initially for the diagnosis. Maybe you can consider differential diagnosis, as Dr. Deepthi was mentioning. So you can rule out other diagnoses with the help of CT scan. You can look for any complications that you get pneumonias or bronchiectasis or any associated disorders like malignancy, which you might miss. Unfortunately, we don't have lung cancer screening in our country, but probably when you do a scan for diagnosis or differential diagnosis, you might pick up an early lung tumor, which might be of benefit to the patient. So keeping that in mind, Dr. Sharada, let me ask you this question. As Dr. Anirudh was mentioning, a combination of ILD and COPD, combined pulmonary fibrosis and emphysema. If you have a patient of combined pulmonary fibrosis and emphysema, for some reason a biopsy has been done, what kind of lung picture do you expect in that?
So, as I've already shown in my presentation, the picture of combined pulmonary fibrosis and emphysema. So, the lung shows features of both emphysema, that is enlargement of the air spaces, as well as fibrosis. So in the literature, in some literature, it is described that the upper lobes show the emphysema and the lower lobes show fibrosis, but practically it is not like that. There will be a mixed fibrosis as well as emphysematous changes in any lobe of the lung. So, and the pattern of fibrosis is mostly the UIP, the usual interstitial pneumonia pattern of fibrosis with dense interstitial fibrosis, fibroblastic foci, and honeycombing. All these changes of UIP are seen. And then along with that, the emphysematous changes. And another thing is even the smoking related interstitial fibrosis can also be seen because most of these patients are smokers. As I've shown in my picture, it is SRIF, even that pattern of interstitial fibrosis is also noted in CPFE patients.
Yeah, thank you. But let me take you a step back. Sometimes when we send a biopsy sample, we don't get enough answer. And then the pathologist said, okay, you have not given me enough history. So what will be the relevant data that should be mentioned in the request form when you're sending a biopsy for, say, a COPD or a COPD-ILD combination?
Yeah, the relevant data which I need in my test request form, and if it is not present in the test request form, I always, before signing out my case, I always pick up the phone and talk to the clinician, and I think I am a bit obsessed with that. I don't know, the clinical details I will need, the symptoms. Apart from that, I will need the other relevant data like, especially the COPD patients, I will need the data of the pulmonary function test, whether it is a restrictive pattern or an obstructive pattern or a mixed pattern that is seen in this CPFE patients. And apart from that, I need the imaging details also, whether there is any fibrosis, what type of fibrosis on the CT, then any small airway disease like air trapping, mosaic attenuation is there. Especially for the small airway disease in the biopsy, it is a it's a minimal change pattern. We describe different patterns in the non-neoplastic lung biopsy. It is a minimal change pattern, meaning that there are very minute changes in the biopsy. So only when a pathologist correlates those features with that of the imaging, the pathologist will be able to identify these minimal changes, which are seen mainly in the small airway diseases. So I will leave the imaging findings, and apart from that, any serology, like, if CTD, ILD panel is done, autoimmune panel is done, or any workup for hypersensitive pneumonitis is done, those serology findings. So all these data, as a pathologist, I will need before I sign out the biopsy.
Yeah, so this is a lesson for all the clinicians. If you want a complete diagnosis from a pathologist or a radiologist, you have to give them a complete history set. Without that, without relevant data, in fact, in our one of the hospitals I work, they mention everything in the test request form. There is obviously patient details, then there is patient's history, then there's other tests that have been done, radiological findings if it is available, and what test have we done, what sample have we taken. So everything has to be mentioned. Only then probably a pathologist is going to be able to help you. Coming to the next diagnostic test, we have spoken about biomarkers, some genetics involvement in the diagnosis of COPD. So, Dr. Deepthi, is there a role to doing these tests, role of biomarkers or genetic testing when the patient walks in your OPD?
Sir, biomarker wise, I would really say I think without a blood eosinophil count, we shouldn't let a single COPD patient walk out. Because not only is it going to guide us for the treatment wise, even prognosis wise, I think high eosinophil count is important. We just spoke about young COPDs. So in young COPD patients whom we are considering, spirometry and follow up and everything, a basic eosinophil count itself is enough to judge whether they are at a risk of COPD. So these young COPDs, PRISM patients, non-smoking COPDs are all people who are, more susceptible to end up with a proper COPD if they are having a high eosinophil count. So eosinophil count is a basic workup and should be included as part of any regular COPD case workup. Apart from that, as Dr. Varuna ma'am has already mentioned, CRP is a very important thing. I think all of us are getting it done in all our exacerbation cases. It is what is basically guiding us whether we need to put in an antibiotic or not. Though there was a lot of talk about procalcitonin and other markers, I think nothing can beat CRP when it comes to guiding us regarding the use of antibiotics in exacerbations. And as far as genetic testing is concerned, though initially we were taught to get the testing done for young COPD, I think at any stage in life when you're diagnosing COPD at any age group, alpha-1 antitrypsin deficiency should be part of that workup, because we might have missed, somebody else might have missed, but get it done. See if he's a candidate for an augmentation therapy. Now, though the talk is about augmentation and it is something which is highly costly and not easily available in all countries, but the fact that it is being trials are being conducted, it is not a far future where it will be available in our country, and it will be relevant in our workups also. So at least the awareness needs to be there when we are handling COPD, that genetic testing may also be part of our workup very soon.
Yeah, so we should be aware of biomarkers and genetic testing. Biomarkers are mainly useful probably in your exacerbations. In a stable COPD patient, a simple eosinophil count or maybe a ABG might help. But if you're looking for an exacerbations, your other biomarkers might help. Genetic testing, probably the role will develop as we develop treatments. If you just diagnose and don't treat, probably it has no meaning. So once we get the enough tools to treat, maybe the genetic testing might kickstart. So probably a last few questions before we take in the audience questions. Dr. Varuna, is there a role for screening for COPD patients? What tools can be used for that?
For the COPD screening, what we are talking from the starting of webinar, the gold standard diagnostic tool is the spirometry, the initial phase that PRISM is to be that ma'am has covered. Then other screening tools have been come and published also, like Oscar COPD score. That's an open screening for the COPD in adults in areas. It is also like 8 questions that is to be asked with a peak flow meter along with that, and to be done in the area where the SS is not there for the spirometry. And other like CAT score capture screening tool is also been developed. It is for the as per the question basis also, and exposure to the risk factor and taking about the PEFR, and low dosity or the CT has to be done if we are taking with the COPD for ruling out an early cancer.
Yeah. So in a community setting, it might be difficult for a patient who's walking in our clinic. Maybe these tools can be used to get the diagnosis or at least the indication that the patient probably is suffering from COPD. So we have spoken a lot about the pathophysiology. We have spoken a lot about the tools that we use to diagnose. So Dr. Anirudh, I would like to ask you a question. A patient has walked in your clinic. You suspect he has COPD. Now, for the sake of audience, can you just make assessment form? What would you do? What would be the initial complete assessment that you would do in a suspected COPD case?
The assessments are like just like in all other medical cases, the assessment begins from the point the patient starts entering the OPD chamber. The patient's facies, if the patient is having puffiness on face, if the posture the patient is maintaining, the, the gait of the patient, how the patient walks, is the patient able to walk properly or with support only. This is just the starting. You know, when the patient comes sits there, so when we take the demographic data, name, age, gender, the address of the patient, so we can get a rough idea of the socioeconomic status of the patient. Again, socioeconomic status is factor for the susceptibility of COPD. Then age also leads to progressive decline in lung function in all the subjects, all the people. So if age is more, then definitely patient will be of COPD. So and gender is not that important these days because study have shown that how equal prevalence of COPD. And uh, then we take the basic history, basic physical examination, height, weight, BMI. That also gives us an idea. And about then we take the pulse, BP, saturation. So if the saturation is low, if the patient is having tachycardia, the respiratory rate, if the patient is having tachypnea, and then as we have just already discussed, the symptoms, that is the complaints of the patient and the signs that we see on physical examination of inspection, palpation, auscultation, percussion. So all these things they have to be included in the our assessment of the patient. And about the tests, most of the tests like ABT, PFT, spirometry, and DLCO, we have already discussed. HR, even HRCT test we have also discussed. And I would like to move one way forward to that point. That after all these tests, which we have all discussed, some biomarkers, as Madam has already told, after we have moved forward from these tests, then because the COPD is coming with many comorbidities, so basic blood investigations, CBC, LFT, KFT, uh, absolute eosinophil count, serum total IgE, and also because the COPD is coming with so many comorbidities like skeletal muscle wasting, osteoporosis, heart failure. So ECG, important test, 2D echocardiography to see the condition of the heart and if the suspected COPD patient is having any features of right heart failure, poor pulmonary, and pulmonary for signs of pulmonary artery hypertension. So I would like to run these tests as well. So these are the things that are on my mind.
Yeah. Thank you. Thank you, Dr. Anirudh. So basically, right from the way the patient walks, the history, the clinical examination, your spirometry, your blood gases, maybe evaluating for other systemic disorders associated with COPD and complications of COPD. So your clinical assessment has to include everything. If there's a smoking history, the smoking history should be mentioned in detail, how many packs a day, if it's a BD smoke, how many sticks a day, or the Jindal index, whatever way you prefer. So all these things should be mentioned in your file so that the patient, if it walks into a cardiologist clinic or a physician clinic, they should know how to evaluate these patients. Now, coming to the last question, which probably I have in my mind, then we'll take the audience question. This question goes to Dr. Sharada ma'am. What are the histological features that you see in an explant specimen of COPD patient who has undergone a lung transplant?
So basically, these patients are severe COPD patients. So patient is undergoing COPD, patient is undergoing a transplant, means the patient is having severe COPD. So the changes, histological changes are also of the severe grade. Like there is severe emphysema. The biopsy picture I have shown in my presentation. There is a lot of enlargement of the air spaces. There is destruction of the alveolar septal walls, and there is severe emphysema. Apart from that, there is severe grade of this small airway remodeling. There is a lot of inflammation and fibrosis, and this leading to the stenosis, the complete stenosis of the small airways. And of course, the pulmonary vasculature shows the pulmonary hypertension changes like, medial hypertrophy and intimal fibrosis. And muscularization of the arterioles. The pulmonary hypertension changes are seen. And apart from that, what we found when examining these explant specimens of COPD patients, where there were additional findings also. In more than half of these patients, the explant specimens are showing additional features, additional histological features in the form of interstitial lung disease, fibrosing interstitial lung disease like UIP or NSIP of connective tissue disease, or features of pneumoconiosis, sarcoidosis. And some studies, they showed that even lung carcinoma was also found in some of the explant specimens because these patients are smokers. So these are all the pathological features which we encountered in the explant specimens of COPD patients.
Thank you, ma'am. I mean, it's a task to see the whole explant lung and evaluate it from top to bottom. It's a difficult task, I can imagine. But to get all these findings is probably pretty fascinating. So now let us just take our rapid fire questions from the audience. We have a lot of questions. I think most of us, we have covered this, but the things which probably needs attention, the first question, I think all the panelists, anybody can just take up. Otherwise, I'll take up. Dr. Saurin Banerjee from West Bengal is asking which inhaler is safe in COPD cases with cardio history. I think, sir, you should wait for the next webinar. This is the first of the part. CCI has been having these kind of webinars for more than 5 years now. So I think we will have a detailed discussion on the inhalers. I would suggest you wait for the next one for this. There will be enough specialists to discuss on that. Dr. Ajay Sabnes from Kolhapur is asking, is there a difference between secondhand smoke and passive smoking? Anybody wants to take that?
I think there is no difference between the two terms. In fact, there's a third term, there is environmental tobacco smoke. So all the three mean the same. Basically, it is when a non-smoker is exposed to smoke because of some other person. So a more technical term is environmental tobacco smoke, but otherwise, in general, a second-hand smoke or a passive smoke is also means the same.
Yeah, so passive smoking kind of be like a broad term, when you're inhaling all the pollutants, also like smoking that, and secondhand smoking or the environmental tobacco smoke can be somebody smoking in front of you. It's very crazy that if you have an air quality index of more than 100, it's probably equivalent to say smoking 2 to 3 cigarettes per day. I don't know how much of us are smoking without knowing it. So coming to the next question, Dr. R. Murli from Andhra Pradesh has asked spirometry for pre-surgical evaluation in COPD patients. What are the criteria that you follow?
We should see actually the patient is going for a surgery. So which surgery is going on? Like if there is an brain surgery, eye surgery, if there is an indication for that spirometry, there is an increased intracranial pressure. So we should avoid the spirometry. And as per the abdominal surgery, we go for a routine spirometry investigation. And along with the spirometry, the history, the examination are also important. And depending on the values of the FE1, FEC, the lung capacity, we go with the fitness for the surgical, and more the surgical side that is it's like near the diaphragm, more would be the complication and the more would be the severity later on.
So if you have an upper abdominal surgery or a supramajor surgery, probably just getting a spirometry makes sense, and you should see the patient's FVC at least should be more than 50% before you are subjecting a patient to a major surgery. But if you're doing surgery for a cardiac disease, probably an aortic stenosis, or as Dr. Varuna mentioned, probably some brain surgery, spirometry may not be done for such patients, and you might want to do other tests to see the COPD fitness or the pulmonary fitness from that point of view. Anybody else wants to add anything? Yes. Let's go to the next question. Dr. C. Suresh Kumar from Andhra Pradesh has asked, what test do you recommend for young adults with emphysema for evaluation? We did speak about young COPD or pre-COPD. So young patients with emphysema, what do you recommend?
You've already mentioned the use of spirometry and the use of blood eosinophil counts and proper follow-up of these young COPDs. That is what is required. Apart from ruling out other differential diagnosis using HRCT and picking up any occupational lung disorder or pneumoconiosis. So I think a proper workup is what is required. The genetic studies, if available, a proper genetic study. So young COPD has not been labeled COPD yet. We are considering that these patients are going to end up as COPD. So if, as the question mentioned, already there is evidence of emphysema, then a proper workup for COPD as any other regular case is required. But follow-up wise, I would say spirometry and eosinophil count.
Now, the only thing I can add is alpha-1 antitrypsin levels. If you have a young patient and probably you don't think the smoking has been, some patients, at least in Mumbai, in my area, they say we smoke 1 cigarette a day. If I exclude the environmental tobacco smoke or the environmental pollution, 1 cigarette a day probably should not land you in a COPD at a young age or an emphysema. Maybe alpha-1 antitrypsin levels should be checked in such patients if you find that. So I think rest of the questions, I think we have pretty much covered. And there are many more questions about the treatment part. I think those will be covered in the next webinars. Let's keep our focus on the pathology and the diagnostics. So if there are no more questions, are there any other questions from the event team? Can you see any more questions? I think we've had a fruitful discussion. We should know what the pathology is of any disease before jumping on to the diagnostics and the treatment part. So I think this was a unique opportunity to interact with Dr. Sharada, a specialized pulmonary pathologist, who showed us a peek from a microscope. How does a lung look? So thank you, ma'am, for this. And I also thank Dr. Deepthi, Krishnan, Dr. Varuna, Jethani, Dr. Anirudh, Saini, who were the panelists for this session and giving the insight on what are the diagnostics and what are the troubles we face in the history taking and the tests that we do. And also the more important part, I would like to thank the CCI team, Dr. N.S. Krishna sir, Dr. Narayan Pradeep, Dr. Ashish Dubey, Dr. Anil Maske, and Dr. Vijay Kumar Chinam Chetty for giving me the opportunity to moderate such a session. Any last words from our panelists before we wrap up for the day?
It's a great moderation.
Thank you. Thank you. So I would like to end webinar here. Thank you. Thank you, everyone. Good night.
Thank you.
Good night, sir. Thank you.
Good night.